Hi, my name is Katarina Monahan, and this is my presentation for diagnosis and treatment of ADHD. So what is ADHD? ADHD is attention deficit hyperactivity disorder. It's the most commonly diagnosed. It's most commonly diagnosed in childhood, and it's approximately the 50th leading cause of global years lived with a disability for children, coming before diabetes, meningitis, and intellectual disabilities. It's the most commonly diagnosed neurodevelopmental disorder across the lifespan. And according to the DSM-5, the prevalence of ADHD in the population, based on surveys in most cultures, is 5% for children and 2.5% for adults. The history of ADHD starts in 1763 with Sir Richard Crichton. He wrote a book where he discussed attention for the first time as a disease. In 1809, Heinrich Hoffmann wrote a story called Fidgety Phil. And the story was a popular allegory for children with ADHD, and it was interpreted as an early case of ADHD. In 1902, Sir George Frederick Still identified ADHD as an abnormal defect of moral control in children, and found that some children were unable to control their behavior in a way that's typical for children and they were not intellectually disabled. In 1968, the DSM-2 was released, and the APA, American Psychological Association, initially didn't recognize ADHD, but when they published the DSM-2, it was included for the first time as hyperkinetic reaction of childhood. And in 1980, when the third DSM was published, they changed the name from hyperkinetic reaction of childhood to attention deficit disorder, or ADD. This disorder came with two subtypes, with and without hyperactivity. In 1987, the APA revised the DSM-3, and they removed the hyperactivity distinction and changed the name to attention deficit hyperactivity disorder, or ADHD. And this included symptoms in one list with no subtypes. The DSM-4 was released by the APA in the year 2000, and this edition identified subtypes of ADHD to include combined type, predominantly inattentive type, and predominantly hyperactive impulse type. And these are this is the criteria that we use today. Risk factors for the development of ADHD. Some temperamental risk factors include behavior inhibition, effortful control or constraint, negative emotionality, and or elevated novelty seeking. These traits are not specific to the disorder, but may predispose children to ADHD. Some environmental risk factors include being born with a low birth weight. This conveys a 2 to 3-fold risk for ADHD, but most children with low birth rate do not develop the disorder. There is some evidence that associates smoking during pregnancy with ADHD, but it reflects more of a genetic risk. There also may be some history of child abuse, neglect, multiple placements in foster homes, exposure to neurotoxins, infections like encephalitis, and alcohol exposure in utero that may correlate with the development of ADHD. Some genetic risk factors include being a first-degree biological relative of someone with ADHD. And the DSM-5 had considerations for these, for things that may influence the development of this disorder, like visual and hearing impairment, epilepsy, sleep disorders, and nutritional deficiencies. Diagnostic criteria. So the diagnostic criteria for ADHD is broken up into 5 sections. Section A is a persistent pattern of inattention or hyperactivity or hyperimpulsivity that interferes with the functioning or development as categorized by one or two of the following. Number 1, criteria 1 is inattention. They have to have 6 or more of the following symptoms that have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impact directly on social, academic, and occupational activities. It is important to note that the symptoms are not solely a manifestation of oppositional defiance disorder, defiance, hostility, or a failure to understand tasks or instructions. And for older adolescents and adults, at least 5 of these symptoms must be present. So the symptoms are A, often fails to give close attention to details or make careless mistakes in schoolwork, at work, or during other activities. So overlooking mistakes or missing details. B is often has difficulty sustaining attention in tasks or play activities. So they have difficulty remaining focused during lectures, conversations, or lengthy reading. C often does not seem to listen when spoken to directly, so their mind seems elsewhere, and even in absence of any obvious distraction. Symptom D often does not follow through on instructions and fails to finish schoolwork, so chores or duties in the workplace, they start tasks, but they quickly lose focus and don't get those tasks completed, or they're easily sidetracked. E is often has difficulty organizing tasks and activities, difficulty managing sequential tasks, keeping materials and belongings in order, messy, disorganized work, poor time management, and failure to meet deadlines are some examples of that type of symptom. F often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. So they are reluctant to engage in schoolwork or homework. For adults, preparing reports, completing forms, reviewing lengthy papers, these things are a challenge. Symptom G often loses things necessary for tasks or activities like school materials, pencils, pens, wallets, keys, phone, or anything, tools. H is often easily distracted by extraneous stimuli. So this may be for older adults, could be unrelated thoughts. So your mind is just going in other directions when you're trying to focus on your task. And then the last symptom for inattention is often forgetful in daily activities. So they forget to do chores, forget to run errands. For older adolescents and adults, it could be returning phone calls or paying bills and keeping appointments. The second criteria for A is hyperactivity and impulsivity. So 6 or more of the following symptoms have to have persisted for 6 months to a degree that is inconsistent with developmental level and that it negatively impacts their daily life. So this starts with A, often fidgets or taps their hands or feet, or they squirm in their seat. B, often leaves their seat in situations when remaining seated is expected. So leaving his or her workplace, leaving the classroom during a class, in other situations that require someone to remain where they are. C is they often run about or climb in situations where it's inappropriate. So in adolescents and adults, this could be just limited to restlessness. D, often unable to play or engage in leisure activities quietly. E is often on the go or active as if they're driven by a motor. So they're unable or uncomfortable being still. And this is experienced by others as being reckless or difficult to keep up with. F, often talks excessively. And G, often blurts out the answer of a question before it has been completed. So this could also be like completing other people's sentences, or they can't wait their turn in conversation. H often has difficulty waiting his or her turn. And then the last one for section A, criteria 2, is often interrupts or intrudes on others. So they butt into conversations or games or activities. They might start using people's things without asking them or receiving permission. For adolescents and adults, this may intrude or take over what others are doing. Section B, for the criteria, several inattentive or hyperactive impulse symptoms were present prior to the age of 12. Section C states several inattentive or hyperactive impulse symptoms are present in 2 or more settings, so home, school, work, with friends or relatives, those are different settings. Section D, there is a clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. So are these symptoms impacting their life? Is it creating disturbance in their everyday functioning? And Section E, the symptoms do not occur exclusively during the course of the schizophrenia or other psychotic disorder and are not better explained by another mental disorder like mood disorder, anxiety disorders, or dissociative disorders, just for example. There are some specifiers. So there are 3 different types of ADHD specifiers: combined type, predominantly inattentive, and predominantly hyperactive impulsive. So the combined type is if both criteria A1, inattention, and A2, hyperactivity, impulsivity, are met for 6 months, then that would be their specifier. They would be predominantly inattentive if they met criteria A1, but not A2 for a period of 6 months. And then the opposite of that, predominantly hyperactive and impulsive, they meet criteria A2, but they don't meet criteria A1 for 6 months. There also are specifiers for impartial remission. This is when full criteria were met previously, fewer than full criteria have been met for the past 6 months, and the symptoms still result in impairment of social, academic, and occupational functioning. So they don't quite meet the same criteria they met before, but they still meet criteria for impaired functioning, so it would be in partial remission. And then also you can specify if it's mild, moderate, or severe, mild being few, if any symptoms in excess of those required to make the diagnosis are present, and symptoms result in no more than minor impairment. Moderate is symptoms of functional impairment in between mild and severe are present. And then severe, of course, many symptoms in excess of those that require to make the diagnosis, or several symptoms that are particularly severe are present, or the symptoms result in marked impairment in social and occupational functioning. I found a lot of different diagnostic tools to diagnose ADHD. So I'm going to start with the interviews. So the standard clinical interview is used to diagnose ADHD according to DSM-5 criteria, and it determines whether or not an individual has ADHD, and this is completed with parent and or child. The KSADS, or the KITTI-SADS, is a diagnostic algorithm that uses the DSM-5 criteria to diagnose ADHD. It's a semi-structured diagnostic interview with parent and child. The items are rated on a 3-point scale for severity: subthreshold, moderate, or severe. Parent and child summaries are rated, and the results of the algorithm will indicate whether or not the individual has ADHD. The DISC, or the DISC-4, is another diagnostic algorithm that uses the DSM criteria for ADHD. It's another structured interview with parent and or child, and the items are rated in yes or no, somewhat, or sometimes, and it's used to indicate whether somebody has ADHD. There are some continuous performance tests. The first is the Connors CPT, and that's a continuous performance test for attention, impulsivity, sustained attention, and vigilance. It's a computerized test, and it tests the responses to a target and a non-target. Raw data is used to calculate algorithms to indicate problems in a given area. The IVA CPT, or Integrated Visual and Auditory Continuous Performance Test, tests auditory and visual response control, auditory and visual attention, and audio and visual sustained attention. This is a computerized test as well, and it tests the response to the target, visual or auditory, and to the non-target, visual or auditory. The TOVA, or Test of Variables of Attention tests the attention and inhibition control using a computerized test that records responses to the correct target and responses to an incorrect target. The CANTAB is the Cambridge Neuropsychological Test Automated Battery. It is a computerized test that tests general memory and learning tests with subsets to include working memory, executive functioning, visual memory, attention, reaction time, decision making, and response control. Excuse me. Scoring variables by domain, and it includes scores as a percentage of correct, number of errors, and time to complete, as well as response latency. The interpretation can vary on this depending on what the outcome measures are. The higher numbers of errors indicates more impairment. The lower response latency indicates less impairment. So rating scales. I found so many of these, and so I'm only going to go over a couple of them. The NIC HQ, or the National Institute for Children's Health Quality Vanderbilt Assessment Scale, assesses for ADHD as predominantly inattentive, hyperactive, impulsive, or combined type. It also tests out for differential diagnoses like oppositional defiant disorder, conduct disorder, anxiety, and depression. And it's a parent-teacher questionnaire with symptom questions that are rated based on a scale of 0 to 3, and performance questions that are rated based on problem severity using a scale of 0 to 5. So positive screening indicates the need for further evaluation. Positive indicating scores are 2 to 3 for symptoms and 4 to 5 for severity. Another rating scale is the Conners rating scale, and this is known as the CPRS, CTRS, CRS, or Conners 3, and it's a rating scale that assesses ADHD-related symptoms and behavioral and emotional symptoms. ADHD-related scales assess inattention, hyperactivity, impulsivity, learning problems, executive functioning, and DSM symptom scales. ADHD Index and the Conners Global Index. For behavioral and emotional scales, they assess for defiance and aggression, peer relations, social problems, family relation, oppositional defiant disorder, conduct disorder, cognitive problems, if they're anxious or shy, if they experience perfectionism, and psychosomatic issues. This scale is done by parents, teachers, and adolescents, and they complete the scales and they're rated based on how true the question is for the child using a 0 to 3 scale with not true at all, a little true, pretty much true, and very true. Higher scores indicate increased clinical concern. And the last scale that I looked at for this presentation is the SNAP-4, or the Swanson, Nolan, and Pelham revision. And this scale assesses ADHD predominantly inattentive, hyperactive, or impulsive, and combined type. And it is a parent-teacher questionnaire, and the questions are rated based on frequency of a scale of 0 to 3, with not at all, just a little, and quite a bit, and very much. Some cultural and ethical considerations. So the prevalence rates across regions appear to be attributable mainly to different diagnostic and methodical different practices. There also may be cultural variation in the attitudes toward interpretations of children's behavior as well. So different cultures believe children behave in different ways. So everybody might look at these behaviors differently. Clinical identification rates in the US for African American and Latino populations tend to be lower than those of Caucasian populations. So I didn't read up on why that would happen, but it's probably a lack of access to mental health treatment, or maybe they don't want to get mental health treatment. Systemic oppression is probably a contributor to why those statistics are there. And it's also mentioned that informant symptom ratings may be influenced by cultural groups of the child and the informant, suggesting that culturally appropriate practices are relevant for assessing ADHD. For ethical considerations, I looked at the ACA's Code of Ethics. So throughout the sections, like in the child welfare section, we're responsible for respecting the client's dignity and promoting welfare for the clients. It's also important to include their support networks, I would think, in the treatment of ADHD, and provide detailed informed consent to both child, adolescent, and parent or adult. It's also important that we take into account personal and cultural values when diagnosing individuals with ADHD. Of course, client privacy, maintaining confidentiality is important for anything therapeutic related. Section E is evaluation, assessment, and interpretation, and I think that this is particularly important ethically, that we use assessment instruments that are evidence-based, and our interpretations are made based on the results of these tests and not by our own personal opinions. And it's also important that we take all of the ethical measures to secure the most appropriate, least restrictive diagnosis possible. I looked at an article by Rosenberger and Rosenberger from 2012, and they stated that there's ongoing ethical discussions about how a clinician or a physician should handle the treatment of ADHD in children. Children's willingness to use ADHD treatments can vary. They might refuse to take their medication, or they might not be able to self-manage their medications, which are really important ethical considerations for successful treatment, because successful treatment is really closely related to medication adherence and results in good psychosocial functioning for children, and that will give them a better chance at a successful future. But of course, you can't force anybody to do anything. So that's where the ethical challenge comes in. And they also mentioned that the ethical challenge to improve compliance, that's a big challenge because it affects autonomy. And another recommendation is that shared decision-making between parent, child, and provider be had. So they recommend a lot of communication between parent, child, and providers to ensure that things are done ethically. Some recommended treatment modalities for ADHD. I looked at the CDC. They had several recommendations for treating ADHD. They suggest behavioral therapy for children, trainings for parents in behavioral management, and interventions for children in the classroom that are behavioral related. So that could be like IEPs, and having like a ed tech help them in class. These approaches can be used together and are most effective if parents and educators work together. So working as a cohesive team with your child's teachers and with their clinician and their psychiatrist, working as a group together is the most effective way to get your kid where you want them to be. For adolescents, they recommend, in conjunction with the previous treatments, organizational skills training and peer interventions that focus on behavior. So they want to include their peers. And for adults, they recommend a combination of medication, psychotherapy, education, and skills training. For medications, a couple of stimulants that are pretty well known are Adderall and Ritalin. There's also some newer medications that are out there. I think like Vyvanse, and there's a couple of other medications that I can't remember their names of right at the moment. And then a non-stimulant that might be used to treat ADHD is Wellbutrin or bupropion, which is the generic name. And those are my resources. Thank you. I hope you enjoyed the presentation.